Looking forward to this discussion and your questions. It's my,
Yep, great. Welcome, everybody. Good morning. First off, for those who, like me, are curious, the award here is not for this session. This will come this afternoon for Dheeraj Yadav, Keeper Mentoring Award. So please come to the afternoon session. But we are talking about chronic pancreatitis this morning, and it's my pleasure to introduce Dr. Vikesh Singh. He's a professor of medicine at Johns Hopkins School of Medicine. His clinical and research interests include pancreatitis and abdominal pain. And can't think of a more qualified speaker to talk this morning about pain and chronic pancreatitis. Yeah.
Thank you for the kind introduction, Phil, and thank you to the organizers of Pancreas Fest to give me an opportunity to speak to you this morning. I have a couple of disclosures, but none are relevant to today's lecture. I think it's important to always sort of state your key points first, because then even if you fall asleep, you'll remember what we were aiming to achieve during the talk. So my first point is that intervention in painful obstructive chronic pancreatitis is focused on the morphology of the disease, despite the fact that neuropathic changes of the pancreas and the central nervous system and not morphology actually better correlate with pain. In other words, the wiring is probably more important than the plumbing. Number two, and this is a little bit at odds with some of the discussion points we had yesterday in the NIDDK symposium. In truth, endoscopy and surgery achieve similar low pain relief rates in patients with painful obstructive chronic pancreatitis. And this is despite the fact that there have been advances in the fragmentation and removal of stones and treatment of pancreatic strictures. Number three, biomarkers to assess hyperalgesia, which is a clinical manifestation of central sensitization, and then tailor therapies accordingly will result in improved pain response in chronic pancreatitis. And finally, and very important, we need to screen for and treat depression and anxiety to improve the pain response in patients with chronic pancreatitis. So now on to the first point. A couple of years ago, a group of surgeons and endoscopists and pancreatologists had come together to come up with what we thought were the main deficits in the field regarding the endoscopic and surgical management of pain in patients with chronic pancreatitis. There were a couple of key points from this review article. One is that there's no relation between pancreatic morphology and pain. However, morphology continues to drive invasive therapies. Number two, neuropathic changes within the pancreas and central nervous system more strongly correlate with pain rather than ductal obstruction. The timing of intervention in relation to presentation impacts pain outcomes. In other words, patients come to see us typically when they're at the height of their pain. But even if you don't do anything and let some time go by, often patients will go back to their baseline. So there's a little bit more of an undulating pain pattern than many of us recognize. And it's important to recognize this when you're managing your patients. The next point is that pain patterns are not static, but can actually change over time. The Dutch Pancreatitis Study Group showed that about 60% of patients change their pain pattern at least once over a median of 4 years of follow-up. So patients can go from constant to intermittent, they can go from intermittent to constant, they can go from constant to no pain. So I think it's important to recognize that, and that's even in many patients who did not receive any intervention. And the final point at the bottom here is that there has been no sham arm in prior RCTs of interventions for painful chronic pancreatitis. And this is certainly a big limitation because we know that the sham response rates for patient-reported outcomes, such as pain, are actually very high. And in fact, systematic reviews have suggested this can be anywhere from 60 to 70% response. So I'm going to focus on the first 2 points a little bit more. We've known since 1980 that irregularity in strictures of the pancreatic duct do not correlate with pain and chronic calcific pancreatitis. And more recently, of course, was the large NAPS2 study, which suggested that once you stratify patients by their various pain patterns and then look at morphologic features of even advanced chronic pancreatitis, you can see there's no correlation between these pain patterns and these morphologic features. What we do know is that over time, and in fact, Golrab Kehan's group published a nice paper in Gastroenterology in 2009 that suggested, based on a very detailed histopathologic review of pancreatic resection specimens, that perineural inflammation, endoneural inflammation, as well as neural hypertrophy and an increase in the density of nerves are more tightly correlated with pain in patients, as opposed to ductal obstruction, which you can see on the left-hand side, ERCP pancreatogram. And in fact, we've even looked at this. We haven't published this data, but you can see that when you actually stain the nerves of patients who've undergone resection for chronic pancreatitis, which is on the left-hand side, you can see not only an increase in the size of the nerves, but also the density of the nerves. Whereas when you look on the right-hand side in a patient who's had a resection for a benign serous adenoma, looking at the pancreas that was downstream from the resection site, the nerves look a little bit more normal. So clearly, you begin to see pancreatic neuroplasticity in these patients who have chronic pancreatitis. What's interesting is that the whole premise behind alleviating pancreatic ductal hypertension goes back to an N of 1 study published in 1970 by a group in Seattle, Washington. And what they did was this was also before the time the first pancreatic sphincterotomy was performed in 1971. So this was a patient with chronic pancreatitis. They had a large pseudocyst, and in that pseudocyst, they inserted a catheter, and they could actually measure the pressure through the catheter, and it was effectively a closed system. And what they realized is that every time they actually exceeded 25 millimeters of mercury of pressure within the duct, the patient reported a pain response. So, this has really been largely the basis for which we have chosen to pursue ductal decompression strategies in the treatment of pain in patients with chronic pancreatitis. However, when additional studies were done, and these now come into the 1980s and 1990s, you can see that when you look at that 25 millimeter of mercury pressure, that really the pain response from the patients is all over the place. So many patients had low pressure and had high levels of pain, and the converse was true as well. So really this correlation sort of broke down with additional studies and larger numbers of patients. Let me go to the next point now. Endoscopy and surgery achieve similar low pain relief rates in patients with painful obstructive chronic pancreatitis, and this is despite advances in endoscopic therapy. These are the three trials which have largely compared, or at least two trials compared endoscopy versus surgery. And then, of course, there was another study that compared lithotripsy versus lithotripsy plus ERCP, but only one went out to 6.5 years of follow-up, and that was the Cahan group study, and they published that in Gastroenterology in 2011. And as you can see, when they lost about 8 patients in their follow-up, that 6.5-year follow-up period. And if you look at the complete / partial pain relief rates, it's 53% in surgery and 25% in the endoscopy arm. So that sort of naturally begs the question that for a surgery, going out to 6.5 years and having a response that's effectively equivalent to a coin toss, I'm not so sure many people would consider that really a robust response. What I find interesting is that the primary outcome of this study was actually the Zbicki pain relief score. And the authors in this paper, they did sneak this in there, but there was actually no difference in the mean Zbicki pain score between the endoscopy and surgical arms at 6.5 years out. What's also interesting, and of course, we don't really talk about this much, is surgery for chronic pancreatitis really one and done. If you look at this series, which was published by, I think, one of the speakers who's going to be coming after me here, 166 patients underwent TPIAT at the University of Cincinnati between 2000 and 2013. 112 had 5-year follow-up data. What's interesting is that about 2 in 5 of these patients had 2 in 5 of these patients had a prior pancreatic operation. So effectively, it was not really one and done. These patients had an operation and then had to come back and actually have a completion total pancreatectomy. Even when we look at the long-term outcomes of total pancreatectomy with eyelid autotransplantation, I think definition drives perception. What I mean by that is the definition of chronic pancreatitis. So if you look at the follow-up period of over 10 years from the largest series of patients who've undergone total pancreatectomy, they report a pain relief rate of 82%. However, it's important to remember that pain was better or improved compared to before surgery. However, 62% reported any abdominal pain. That might have been different than their pancreatitis pain. 18% reported pancreatic pain, and 37% were on opioids at 10 years. So sort of begs the question, were we selecting the right patients? And I think a lot of these questions are going to get answered by the recently completed prospective observational study of TPIAT that was led by Melina Bellin and our colleagues at the University of Minnesota. Many of the members of the audience are part of this study. And I think by the end of this year and the beginning of next year, we're going to start to see some really interesting outcomes and observations from this study. Now, of course, everyone wants to talk about the ESCAPE trial, and certainly this randomized control trial showed a benefit of early surgery over the endoscopy first approach by the Zbicki pain score. But interestingly, if you look at the complete or partial response at over the 18-month follow-up period, there was no difference between early surgery and endoscopy first. And what's even more interesting, and of course, nobody wants to talk about this, is if you go to the supplementary online content, e-figure number 3, if you actually compared, if you look at the curves of those patients who had endoscopy first without successful ductal stone clearance, and you looked at patients with endoscopy first who had successful ductal stone clearance, you can see that the patients who had successful clearance of their duct of the obstructing stones had an outcome that was very similar to the patients who actually had surgery. So it sort of begs the question that if you utilize all the technologies that are available to endoscopists to clear stones, we can do just as well as a surgical drainage procedure. And really, then the question is, why the difference? There was really no difference in morphology between the patients who had successful versus unsuccessful ductal stone clearance. And they also look no different than the patients who had surgery. But then one of the questions that comes up is, was there enough shock waves applied at the time of ESWL? In the ESCAPE trial, they gave 2,000 shock waves each day over 3 days. But if you go out and you look at other studies which have shown successful ductal stone clearance, you can see that the number of shock waves easily, I'm sorry, this is just very, very sensitive, easily exceeded the amount that were given in the ESCAPE trial. So you're looking at 2,000 versus 4,300. And of course, in the Tandon study from the Asian Institute of Gastroenterology in Hyderabad, India, 5,000 to 6,000 shock waves at each session. So how you do ESWL as an adjunct to your endoscopic therapy can have tremendous impact on successful ductal stone clearance. So would pancreatoscopy guided EHL or laser have helped to improve ductal stone clearance rates? There has been, this is part of the expanding arsenal of tools available to the endoscopist, and this was not available to the study investigators in the ESCAPE trial, because this has really just come online over the last couple of years. But that you can see that, of course, at expert centers, 109 patients treated over this 2-3 year period, about 90% achieved successful ductal stone clearance, and 74% only required 1 session, which certainly can also improve the efficiency of the procedure. Recently, there was a prospective study looking at a pancreatoscopy guided EHL by Marco Bruno's group in the Netherlands, 34 consecutive patients, 71% with complete or partial stone clearance. And you can see the Zbicki pain scores in these patients from baseline to 3 months to 6 months. You can see there is certainly a decline there. And if you start to look at it compared to, of course, the 18-month outcomes of the Zbicki pain scores in the surgical and endoscopy arms of the ESCAPE trial, they're not really that far off from one another. So, again, we're good at getting rid of obstruction. We're probably not as good at getting rid of the pain. Would metal stents have helped to treat dominant pancreatic strictures? We know that there was recently this prospective observational study looking at soft self-expandable metal stents to treat painful pancreatic duct strictures secondary to chronic pancreatitis. And the primary endpoint was complete or partial pain relief as measured by the Zbicki pain score at 6 months after removal or migration of the metal stent. And this was achieved in about a quarter of the patients. So very, very similar to some of the pain relief rates that we had seen in endoscopic studies from before. They also looked at responders versus non-responders, and they looked at factors associated with being a responder in the adjusted analysis, which included not being on opioids, not requiring PERT, which might suggest you don't have as advanced disease now requiring treatment for exocrine insufficiency, and interestingly, a lower baseline weight. So just to quickly go through some of the biomarkers to assess neuromodulators to treat hyperalgesia. I'm not going to spend a lot of time on this, but central sensitization is a complicated concept, but effectively what you have is nociceptive phenomenon where you have ongoing sensory afferent barrage from the pancreas back into the central nervous system, which results in progressive amplification of the pain response that can generalize and persist even independent of the source. And this may be one reason why some patients who undergo TPIAT do not have a successful pain response, because they're just so sensitized. There are clinical indicators of central sensitization. And interestingly, when we see patients with chronic pancreatitis, a lot of our patients with chronic pancreatitis have these clinical indicators of central sensitization: depression, anxiety, hyperalgesia, allodynia, stress-related pain, fatigue, poor sleep, and the last one I think is commonly missed by us, but autonomic dysfunction or POTS, because remember the primary nociceptive afferents travel alongside a lot of the nerves of the autonomic nervous system. So it's not uncommon to have a patient who has orthostasis, but also has pain. So, and if you fix the pain, what's interestingly is often the autonomic dysfunction improves. There are some tools that are now being used to help phenotype pain. One is quantitative sensory testing. And I'm not going to spend a lot of time on this, but this involves using pinprick devices, pressure algometry, and something called the cold pressor test, where you use an ice water bath. And this is a new and simplified testing protocol based on some earlier iterations of the types of tests we were performing. And our group, us in conjunction with the University of Pittsburgh and Aalborg Medical Center in Denmark, helped to develop and validate this as part of an effort known as the PQST Consortium. So while we were 3 centers in 2017, we've expanded out and now have nearly two dozen centers. So we are really hoping to sort of explore this a little bit more. And this test utilizes the convergence of the visceral and somatic afferent nerves in the spinal cord to facilitate surface testing of the pancreatic viscerotome, or otherwise known as the T10 dermatome. And of course, we also can test the condition pain modulation using the ice bath. This is a simple schematic of how this works. Nociceptive impulses will travel from the pancreas back into the spinal cord. And of course, that then wraps around and you actually feel the pain at the T10 dermatome. So this is really what we call the viscerosomatic sensory convergence. And I won't get into how QST is, how do we actually determine the 3 pain phenotypes, but the testing effectively categorizes patients into widespread hyperalgesia, segmental hyperalgesia, and no hyperalgesia. And we have shown that, in a population of normal patients, that you begin to see some separation from normal to segmental to widespread. And when you start to look at patients with chronic pancreatitis, it sort of breaks out into about 50% being normal, 28% having segmental sensitization, and the widespread sensitization being found in about 20% of patients. And what's interesting is that pain response rates seem to be to invasive procedures seems to be dictated a little bit by what your pain phenotype is. So if you have no or segmental hyperalgesia, you do better with intervention than you do if you have widespread hyperalgesia. And this was a study that was just recently accepted for publication in Pancreas as a pilot trial.
Dr. Singh, can we wrap in 2 minutes?
Yes, I'm going to quickly finish up here. We all know that pregabalin has been studied to reduce pain in a trial conducted by our colleagues in Denmark. This was a 3-week trial that showed a reduction in the average daily pain scores in the patients randomized to pregabalin versus placebo. And what was interesting is that QST actually told us which patients were more likely to respond to pregabalin. And what's interesting is that now this has been utilized in conjunction with endoscopic ductal stone clearance in a trial conducted by our colleagues at the Asian Institute of Gastroenterology, where they show that the combination of antioxidants and pregabalin versus placebo, this is after somebody who's had successful ductal stone clearance, can achieve pretty high pain response rates. I'm just going to quickly finish up with, we know that painful chronic pancreatitis can lead to clinical depression or anxiety, or is it the genetic susceptibility to depression or anxiety that lead to pain in patients with chronic pancreatitis? Which came first, the chicken or the egg? We know that clinical depression and anxiety are associated with pain and quality of life. And you can see across the different pain patterns, as you get up to constant pain, very high rates of depression and anxiety. But we also know that genetic susceptibility can drive constant to severe pain phenotypes in patients with chronic pancreatitis. And most importantly, and this is what I'm just going to finish up with, is when you look at 3 variables, ductal obstruction, hyperalgesia as measured by our pain phenotyping test, and psychological distress, the most important one in the multivariate analysis with regards to its association with pain is actually psychological distress. And that's why I say, if you don't screen for or treat psychological distress in our patients with painful chronic pancreatitis, we're not going to achieve the outcomes we're looking for. And with that, I'll finish up. Sorry for going a little bit over.
Thank you, Dr. Singh. It is my pleasure to introduce Dr. William Nealon, who yesterday gave us a wonderful introduction for his talk today. Dr. Nealon is a professor of surgery, he's a chair and chief of gastrointestinal and pancreatic surgery in Northwell, New York. Welcome. He's going to talk to us about pancreatic drainage procedures for chronic pancreatitis.
Good morning. Welcome. Really happy to be here. I want to say just briefly, I don't know if any of you who are not surgeons in the group have ever heard of Claudio Bassi, but he tragically died about 2 weeks ago. He created a center in Verona that was internationally known, and he came up with standards for surgical management after patients who have had a Whipple, for example, the international grading system for fistula. So I just want to mention his name. He's a great loss. I'm an old friend of Dr. Singh's, and so I'm troubled to tell you that he and I couldn't disagree more. And I think if there's anything I'm going to give you at the end of this, I'm going to convince you that the only answer in chronic pancreatitis is surgery. And I'm going to try to explain to you why some of the literature on surgery looks as bad as it does. And it's not because we really don't have very good surgeons, but I'll give you some reasons. Anyway, next slide. I have no conflicts. So I put this in the front, and part of my theory for why you're not seeing great outcomes in surgery is going to be explained by these few first slides. I associate myself with other surgeons who call themselves pancreatic surgeons where I work now. And throughout my career in American surgery, I try to warn people that the population of pancreatic surgeons in America largely is made up of those who have done a fellowship in surgical oncology, in which you have 2 years of surgical oncology and 3 months of pancreas surgery and 0 months of pancreatitis. So their overall knowledge of pancreatitis is close to zero. Now, only because I spend a lot of time in conferences with these people, in spite of that lack of knowledge, they don't ever hesitate to pretend that they know something about it. And what is the reason that they're not enough people are getting the surgery or getting an inadequate operation is because of that fact. And it's literally all over America. At any rate, to try to prove this to them, the American Board of Surgery used to make you come in every 10 years and recertify. Now they have a test that you can take, an open book test, once every 2 years, and they send you to you. 20 of those are general questions, and 20 are specific to what other customized thing you chose. So for mine, you would be not surprised that I chose HPV. Next slide. So here was the question that was on this test. A 72-year-old female non-alcoholic abuser was hospitalized every 6 weeks for the past 3.5 years. And I'll just mention that this subset of chronic pancreatitis, which is not rare, hasn't been mentioned yet. But there's two categories. One is everyday pain. One is the ones who have intermittent acute attacks and repeatedly come to the hospital. Anyway, she came in every 6 weeks for 3.5 years. Each admission is for abdominal pain and nausea. Variably, she'd have enzyme elevations or not. And the imaging is as follows. Next slide. So she has a dominant mass in the head of the pancreas, which is a significant part of what we're talking about with the surgery for chronic pancreatitis. How much does clearing out some stones matter when you have a big inflammatory mass like that? Next slide. And then here you can see that there's a dilated duct in the body and there's calcifications throughout. Next slide. And there's just some more calcifications all the way out to the tail, and you can see the duct all the way out to the tail. Next slide. So an intervention was chosen, and this certification exam asked you to choose among these five, either a Pusto, a Whipple, endoscopic, pancreatic duct stenting, or extraction of stones, Fry procedure, or TPIAT. And you'll have to wait till the end to find out what the answer was. Next slide. You can go to the next slide. That's unreadable. But Japanese Society of Gastroenterology came up with a fairly extensive survey throughout all of Japan that were part of this society. And they first came up with a new, not that we needed one, but a new definition that chronic pancreatitis is a pathogenic fibroinflammatory syndrome in which a persistent pathologic response to pancreatic injury or stress occurs in individuals with genetic, environmental, and/or risk factors. Next slide. So they came up with these terms. There's what they want to call new or early chronic pancreatitis, established chronic pancreatitis, end stage, when we know the idea of a burnout chronic pancreatitis. And then they do mention RAP, which I think is really a separate entity. And easily the most challenging one for any of us who manage pancreatic disease every day. Next slide. So they ultimately came to the assumption that surgery is ultimately necessary in up to 80% of patients, which is a big difference from what you just heard. And I can only tell you it's a he said thing that you're going to have to deal with. Repeated endoscopic interventions should be avoided. The record I have in my career is 46 in endoscopic interventions before the patient finally found their way to a surgeon. Surgery should be, their other recommendation was that surgery should be recommended early in the course of the disease. Next slide. So we know, most of us, everyone in the room knows this, it's characterized clinically by either daily pain or recurrent acute episodes. And I have a publication, I've been writing about this problem for about 35 years, by the way. And I think I'm not aware of too many that have mentioned this subset of patients who have recurrent acute. What I was able to find in that report was that 70% of those with recurrent acute attacks, those can be abolished completely. And in the other 20 or some percent, they're reduced significantly compared to before surgery. So that subset, I would say, is an ideal candidate for surgery. And I don't know that they'll get any help from an endoscopic intervention. As the disease progresses, we know we have loss of function, both endocrine and exocrine. Next slide. And next slide, that's just the anatomy. And that's just the histology. Next slide. So for etiologies, we know that alcohol abuse is out there. We have genetic causes, and it's has been mentioned here and yesterday. You know, obviously we know people who drink too much and they don't get pancreatitis all the time. And listening to all the patients all these years who have had alcoholic pancreatitis, they are not always the ones who are just not able to stand up at the end of the night. So we clearly have a combination of the initiating event. That may be true of gallstone pancreatitis as well, as David Whitcomb said earlier. But anyway, we have genetic causes, ductal injuries, and they can come from any variety. I've taken care of my share of patients who have disrupted halfway across their pancreas with pancreatic trauma. They've broken their pancreas in half. Most recently, I took care of a little 22-year-old girl came all the way from West Virginia who had gotten in a car crash and had broken her pancreas in half. I was in Texas for many years and got someone who was kicked by a horse. We have tropical pancreatitis. We have systemic diseases, some of which are associated. Autoimmune, as we know, is a separate entity, and idiopathic used to be the most common cause after alcohol in what I call the conventional chronic pancreatitis, which means calcifications of the gland, dilated duct, and now we are addressing more of a separate population, which I'll mention. Next slide. So how do they present? Mostly they present with abdominal pain. The recurrent acute attacks is out there. They can either present or progress to the functional derangements. And we know about things like pseudocyst, pancreatic ascites, which is almost always a ruptured pseudocyst. We can have fistulas. You can have bile duct or duodenal obstruction, and not unlike cancer, the same mass in the head of the pancreas that you can see with chronic pancreatitis, of course, can do the same thing that it does with a cancer. So it can obstruct all three, obstruct the pancreatic duct, obstruct the bile duct, and obstruct the duodenum, all three of which may need to be dealt with when you're trying to deal with patients with these problems. Splenic vein thrombosis is extremely common. Pseudoaneurysms a little less, but if they bleed, they're extremely annoying. And we do know that cancer is the patients with chronic pancreatitis have 100-fold increased risk of cancer. So unfortunately, just to make it even more fun to diagnose, you may have both. Next slide. And for the diagnostic evaluation, we already know everything about this, but you're going to get CT, MRI, endoscopic ultrasound, ERCP, and then certain laboratory testing. Next slide. And for the treatments, it's I think that most of us who have a pancreatic center like I've created in New York, what you need to be doing is evaluating a very complex problem with multidisciplinary group. You have to have surveillance, and there are at the bottom on the left side, endoscopic, medical, and surgical treatments. And then the group can be as long as this list, with pancreatic surgeons, pancreatologists, therapeutic endoscopists, interventional radiologists, endocrinologists, geneticists, social services, nutrition, pain management, addiction medicine, which is not the same as pain management anymore in America. You go to a pain clinic and you get a block of some kind, psychiatry, and finally transplant if you're looking at TPIAT. Next slide. So the historic perspective is that over the last half of the 20th century, virtually all the literature on chronic pancreatitis, surgery for chronic pancreatitis, referred to these patients that I mentioned a minute ago. They have parenchymal calcifications, they have a dilated duct, they're frequently alcoholic. There is a subset that has a non-dilated duct, and idiopathic used to be the second most common cause. So that was the world I grew up in until about the turn of the 20th to the 21st century. Next slide. There were innumerable papers published, and so this is not without a significant and extensive literature, and including randomized controlled trials. So everything was compared. So Whipple was compared to Pusto, Whipple was compared to Fry, Fry was compared to Pusto, surgery was compared to endoscopy. Next slide. And this is sort of a repetitious slide, but it mentions some of the exact genetic mutations that we already know about. And ultimately, in this assessment, 40 to 75 of patients ultimately undergo surgery. And the anatomy, as Dr. Singh mentioned a minute ago, of the duct and the morphology of the duct does dictate somewhat the management, because if you don't have a dilated duct, then you have so-called small duct disease. There's a good question, what are you going to do if you have all of these changes, again, in the classic calcific pancreatitis, but you don't have a dilated duct? It's a challenge. I finally have gotten so that I can do the Fry procedure in those patients as well. Next slide. And so the indications for surgery, as we've already seen, is refractory pain, which is a significant one, quality of life, frequent hospitalizations. We've already said those things. Next slide. So this is actually a little drawing from the original Pusto, and the non-surgeons would have no reason to know this, and I'm suspicious that many surgeons wouldn't, but this is a resected body or tail of the pancreas with the spleen. So there was someone named Duval in the 1950s and 60s who decided there was no valves in the pancreatic duct, so if you just cut off the tail, since the assumption always has been that pressures are too high, and if you just decompress it, then get something out of there. It's equivalent to the endoscopic sphincterotomy of the pancreatic duct that the endoscopic people do. This was done back 20, 30, 50 years ago, thinking which should achieve the same thing as an endoscopic sphincterotomy of the pancreatic duct. It's just going to say, let all the juice out. That failed miserably. The Duval was abandoned. Pusto, I always like to say we should use Pusto's name because he's the one who came up with the idea of doing a fillet of the opening of the pancreatic duct here just in the body. But the actual Pusto that evolved was actually named after Partington and Rochelle. Next slide. And they actually are the first ones to come up with not taking out the tail. That's the only difference they made. And then they also recommended that you do a deep incision well into the uncinate process. And that's the piece where I think even from the literature in the late 20th century is flawed, because the problem with recommending going into the uncinate process as a surgeon is that it gets deeper and deeper. So you suddenly may have a 2 or 3 inch deep cavern in the head of the pancreas full of gigantic blood vessels, and there's lots of bleeding, and everybody runs for their lives and sort of limits the amount of opening into the head of the pancreas that is required to get the right outcomes. Next slide. And then pancreatic duodenectomy, as you know, is out there. Too often in America, I would say, if you ask someone who calls themselves a pancreatic surgeon in your hospital, they're either going to say there's nothing to do, or they're going to tell you that they need a Whipple. And I'm here to tell you they don't need a Whipple. The only one is the very bottom, where if you have a real suspicion for cancer, you should do a Whipple. Next slide. And this is the original drawings from Charlie Fry of the Fry procedure, in which this case he does an extension of the incision in the side of the pancreatic duct, but then does an excavation of the head of the pancreas. And this is an exposure of the bile duct. And so in this case, you get rid of that large inflammatory mass that we mentioned. And in my opinion, this mimics what was recommended in the late 20th century, which is making an acceptable incision all the way down into the head of the pancreas. And in this case, you can't avoid it if you're doing that excavation. Next slide. And this is just the Bager. Hans Bager reported from Ulm, Germany for many years. In many ways, he was the first to come up with this idea of the excavation of the head. These operations, in my opinion, differ by about a millimeter or two, and they should have very similar outcomes. Next slide. And this is relatively unreadable, but what you can see on this middle column is all these are compared to PDs. So they're comparing either the Fry or the Bager procedure to PD, and in each case, the Fry and Bager were found to be superior to a Whipple procedure. Next slide. And in this, they found even in a long-term follow-up that actually long-term patients after a Whipple for chronic pancreatitis had a considerably higher mortality rate and a worse outcome, only for proving that you should avoid Whipples in general for this disease. And that's the problem, is that most of the surgeons calling themselves pancreatic surgeons only know how to do that operation. Next slide. So the Fry, the pain relief, is superior to the drainage alone due to the removing of that pancreatic head. And I really do believe that's the difference. Again, it takes some cojones to decide to cut a hole in the head of the pancreas. It's sounds crazy if you've never done it. And I think that's the reason that we had failures of some of those pustos, was the fact that we had no incision all the way into the head of the pancreas like you now see in a Fry. There is an increased risk of bleeding. And in general, it's can be challenging. Next slide.
Dr. Nealon, if we can wrap up in a couple of minutes.
Yeah, I got started very late, as you know.
Sorry.
I did a publication when I was a baby. I published a paper where I standardized. So it was published in 1993. Most of you may not have been born. Next slide. And what we did was I came up with a method to grade the severity of chronic pancreatitis. And I found that there was a subset of patients who were not candidates for surgery. So when I took the less severe, those that were graded less severe, I had a subset of those that we underwent on operation and a subset that did not. And what we found over time, because then we brought them back and brought them back and brought them back, is that over time, there was significant preservation of function in the patients who had had a drainage procedure compared to those who had not. So it's one of the things that has suggested that earlier intervention is best. This was largely read and referenced in Europe and uniformly ignored in America, but it's actually an important paper. Next slide. And again, early RCTs, and this one here is from the Czech Republic, and another one down below from the Netherlands, again showing an advantage to early interventions. Next slide. And this is just to show that when you compare Bager and Fry, they're literally identical, which is no surprise because the operations are nearly identical. Next slide. I'm just mentioning quickly recurrent acute because Greg coming next to me, and he's coming from a really proud place in Cincinnati where they've done spectacular work. So I'm very briefly going to only say that TPIT, I believe, has no role in calcific chronic pancreatitis with the large duct. I think the outcomes for conventional operations, which is a Fry procedure for this group, is so superior to TPIT that it should not be considered. However, I do think it's the only answer for RAP and hereditary pancreatitis and divisum. Some of these people who have 100% normal pancreas but recurrent pancreatitis. Next slide. And so next slide. So this is all just TPIT, which I threw in, but I'm not going to talk about it because the next person is next. And next. And this is just my version that I think the perfect candidate. Well, Greg's going to tell you that in the next slides. The next. So, and then this is just talking about the person that Greg works for. And I will only reference for you this publication. Next slide. Was reported at the Southern Surgical. And it looks at the long-term outcomes. He has 20 years experience with both TPIT and with what he calls duodenal preserving pancreatic head resection, which used to be what term used for Bager, but it actually is, he uses it to include both Bager and Fry. Next slide. And the clinical data on how he came to these conclusions and the fact that he has 493 patients that he's reporting on. It's really a spectacular paper that I would refer to you. Next slide. And here he talks about how he chose which procedure for which subset of patients. Some had, as I say, he lumps all of these, and these are all Fry or Barron or Pusto or Bager. Next slide. And again, next slide. I think the only important thing I want to mention, I'm not sure Greg's going to mention this, This is the etiology of all of them, but it's a mixture of TPIT, which is a very different population from those that require the Fry or the Pusto or the Baker. Next slide. And this shows surgical management with good outcomes. Next, I always tell us the evolution of the procedures. Next slide. So I just wanted to show this one. He did show some important and I think first time information that when you've done the surgery and they remain severely on narcotics, their survival is significantly reduced. And I think it's an important piece in any of these patients to know that some kind of very aggressive efforts to remove the patient's addiction to narcotics is key to having success in this subset of patients. Next slide. And so in summary, the disease and the patient population of candidates for TPIT differ significantly from what I term conventional chronic. Predominant female and predominant male is what we see in the two populations classically, non-alcoholic for alcohol versus alcoholic, rare calcifications versus common, and the most appropriate procedure for calcific is the Baker or the Fry procedure. TPIT is best applied for RAP, hereditary, and pancreas divisive. Next slide. And so in conclusion, the goals of therapy are durable pain relief and preservation of pancreatic function. Early surgical management leads to better outcomes. Oncologic resection is favored approach if you have any concerns for malignancy. And I do have a concern that there exists a knowledge gap among American surgeons primarily trained in surgical oncology. Next slide. And so the answer on the certification exam was Fry procedure. Thank you.
All right. It's my pleasure to introduce a fellow Ohioan, the third speaker of the session, last speaker, Dr. Gregory Wilson from the University of Cincinnati. He'll be speaking about total pancreatectomy and islet cell autotransplantation for the treatment of chronic pancreatitis.
Well, good morning. Thank you for that introduction. I really appreciate this honor to be here. And I, be discussing total pancreatectomy and islet cell autotransplantation. And I appreciate Dr. Neal and Dr. Singh starting this off. And as the old adage goes, I would say, age before beauty, but I don't think that fits here either. I have no disclosures, and really this needs no background. But I do agree a significant portion of these patients are going to go on and require surgical intervention. The number I usually quote is about 30 to 40%. Dr. Neal had a higher number. It's really hard to pin this down based on where you look. You could pick any number you really wanted to and put a reference on there. The mainstay surgical intervention really relates to drainage of dilated ducts and resection of diseased parenchyma, and maybe a combination of both. When we look at indications for operation, Dr. Nealon covered this quite extensively, so I won't go into it, but really the overwhelming reason why we see these patients is with incapacitating pain, debilitating pain with a reduction in quality of life. That's why the majority of these patients really come to see us to discuss surgical intervention. And I would say, there really doesn't need to be much disagreement here. I think sometimes we cite, endoscopy versus surgery. It's a continuum. And we all know that patients are going to progress through things, and the ones that are managed endoscopically, great. I hope they don't ever need surgery. But I will tell you that some of these do progress on and do ultimately require surgery. Patient selection is absolutely critical, okay, for all of the surgical managed chronic pancreatitis, not just total pancreatectomy. Patient selection is key. Surgical decision is really based on disease morphology. It's regarding the ductal anatomy, whether it's strictures, stones, dilation, as well as the extent of parenchymal involvement, whether it's focal, diffuse, calcific, as both of my speakers before me discussed. The traditional chronic pancreatitis operations, as Dr. Nealon covered extensively, I won't go into, but also anatomic resections can be required in certain situations. But what do you do for patients who have small duct or minimal change disease, or patients that have an entire gland at risk with a hereditary syndrome or genetic syndrome? And then the third category is, what do you do for patients who have progressed despite a previously thought to be definitive surgical operation? So failure of a previous chronic pancreatitis operation. This is really where we think total pancreatectomy islet cell autotransplantation comes into play. By removing the complete pancreas, you remove the inciting factor. Obviously, Dr. Singh talked about some of the neuropathic pathways that are extremely important in managing these patients. But you also mitigate type 3C diabetes by injecting the isolated islet cells into the portal vein. These islets are isolated from the resected pancreas, methods well described. And really, when I talk to patients, what are the goals of this operation? Well, the goals are to improve the patient's pain that they present it with, to improve their quality of life, which is really the most paramount thing. They can deal with some pain, but they want to get back to living a life. And that's usually where we see most of this. And I focus some of the long-term outcomes on that. The other goal is to really provide them with stable glycemic control. You know, we say insulin independence, and I think it's a lofty goal, but really we know that that's not the case. The majority of these patients are not insulin dependent. They do require insulin. They do have insulin dependent diabetes, and we want to just provide them an opportunity to have stable control of that. This procedure is really pioneered in the 70s, as you can see in 72 and 76 with some of the animal models leading up to the first total pancreatectomy islet autotransplantation in 1977 at the University of Minnesota, which they published their results and have continued to publish their results over the next several decades, which ultimately resulted in this kind of seminal paper in 2012 out of their group presenting on over 400 patients undergoing total pancreatectomy and islet autotransplantation for chronic pancreatitis. Here's our experience, and I bring this up, lost some of the slides there, but that's okay. We really thought, where does this procedure fit in? And it fits in where no other surgery does. And that's these patients with small duct or minimal change disease, patients with genetically linked pancreatitis, which have an entire duct at risk, failure of prior surgery for chronic pancreatitis, and those patients, as Dr. Nealon mentioned, with a recurrent acute pancreatitis and a miserable quality of life. So we established some of the early safety metrics and outcomes in this procedure, as well as some of the several other groups. This is one of our first papers looking at total pancreatectomy as the initial treatment for minimal change or small duct disease. What you can see here, and I don't present the surgical data because the safety of this operation has been well established, but you can see that while almost 40% of these patients are insulin independent at most recent follow-up, and almost 60% of them are narcotic free. As Dr. Nealon pointed out, these patients are a different type of patient population. Demographics are not the same as your traditional chronic pancreatitis population. And the most important metric for all of these is quality of life. Okay, and these quality of life surveys show that these patients were able to get back to their life that they wanted to live. We put numbers on it, but really all you got to do is see them in clinic. Took that one step further and really looked at a Markov model to model this, and did this make sense? And you could see when putting that Markov model together, there was an improved quality adjusted life and cost for using total pancreatectomy and islet autotransplantation in this patient population compared to medical and endoscopic therapy. We also demonstrated similar findings with patients who had genetically linked chronic pancreatitis. And one notable thing, I really want to bring this up because I think this is important, right? Because we can argue all day what's the right operation. But what we wanted to show here is that you're right, some of these patients do progress. This disease does progress. We think it involves one part of the pancreas or have dilated ducts, but they can have recurrent disease. And these patients can be salvaged with a completion pancreatectomy and islet autotransplantation. Now, those patients that did end up have a lateral pancreatic jejunostomy as part of their operation did have lower islet yields. However, they were able to achieve good long-term outcomes, okay, because, the majority of these patients were narcotic independent. Less patients, only 20% of these patients were insulin independent at short-term follow-up. These patients did demonstrate an improved quality of life after this completion pancreatectomy as a salvage therapy for previous surgery. And so at our institution, that's really how we refined our patient selection criteria. And again, as I said, this is absolutely critical to manage these patients. And so for patients that have genetically linked pancreatitis, minimal change or small duct disease, recurrent acute pancreatitis, and failure of previous surgical intervention for chronic pancreatitis, these are the patients we identify as potential candidates for a total pancreatectomy and islet autotransplantation. Other patients, calcific disease, dilated ducts, as Dr. Nealon pointed out, we do consider more traditional chronic pancreatitis operations. And I think you have to really evaluate these patients on a one-by-one, case-by-case basis. You can't take an entire blanket summary to all these patients. Now, should we extend the indications for total pancreatectomy and islet autotransplantation? And I think this has been done, and I think it's worth noting. This is the group out of University of Alabama, Birmingham. They looked at the outcomes in islet autotransplantation and total pancreatectomy for patients with alcoholic-induced pancreatitis. What they show was that patients with alcoholic-induced pancreatitis had lower islet yield, And really the kicker to this entire study was that these patients with alcohol-induced chronic pancreatitis had almost no improvement in quality of life with this operation. And so in this setting, I don't think so. I think this points to Dr. Nealon's point. These patients should be considered for traditional operations if they need it. One other thing I wanted to comment is should we consider total pancreatectomy outside of transplantation in the setting of pancreatic neoplasms? This is a paper out of the group in Milan, which they did use this procedure, whether it was part of the pancreas or the entire pancreas in a setting of pancreatic neoplasms. Patients with pancreatic ductal adenocarcinoma, distal cholangiocarcinoma, pancreatic neck and body tumors, as well as those that they deemed high risk for pancreatic anastomosis leak or developed a grade C fistula after resection. These are the patients they considered this in. Now, I offer this up as a word of caution. They demonstrated good short-term outcomes. Median follow-up was under 2 years. And this is out of the group out of Minnesota. We can see that a patient developed metastatic pancreatic adenocarcinoma after islet cell autotransplantation. Patient did not have a known pancreatic neoplasm, but presumably was high risk for it and had an incidental one at the time of the procedure. And so I think this should really be taken with caution. This should not be considered in most places. I think if it's going to be done, it needs to be in the setting of a clinical trial and very closely monitored. And I frankly, I don't think I would offer it to a patient. I don't know why you would. I think there's too much risk with it. And so again, based on that, these are kind of the indications we think are the ideal for total pancreatectomy and outside of transplantation. We were excited to see that, this report from the consensus guidelines on the role of total pancreatectomy outside of autotransplantation really kind of coincided with our thoughts on it. And it's always nice when you see multiple different sources, people thinking the same thing. This is really the kicker of it all. What are the long-term results of this procedure? Is it a durable operation? Are we seeing short-term benefits and only for patients to fail down the road? And really, I think we break this down kind of into 3 categories: pain, endocrine function, and quality of life. I really think quality of life is by far and away the most important metric for these patients. And we initially published our results at the 5-year outcome in 2014, and subsequently recently followed up with a 10-year update on outcomes. And so I'm going to show you a summation of some of these outcomes. Patient demographics here, just to highlight that these are different patients than your traditional chronic pancreatitis population. They're younger patients. They tend to have normal body masses. They're higher predominance of females. They have more idiopathic and genetically linked pancreatitis and very few alcohol-induced chronic pancreatitis. So long-term pain relief, at 76% of patients at 10 years are narcotic-free. Now, I know we can throw, we don't have pain scores on that, and I agree that's definitely a limitation. But these patients that were narcotic dependent, bouncing from one narcotic prescription to the next, are now narcotic independent and completely free of it 10 years out. You can see the narcotic requirements. There are still some patients, and I think patient selection is key. Doing this in a multidisciplinary fashion where you establish the diagnosis. I think early on we were fooled and some patients took them for this procedure, and I don't think chronic pancreatitis was really the problem. Regarding endocrine outcomes, at 10 years, 11% of patients are insulin independent. There is some decline in endocrine function and the durability of these islets transplant in the liver. You can see a slight increase in insulin requirements, but you can see persistent function in these islet cells 10 years out. It's good to know that these islets, when they take up residence, they're there and they don't just go away within a year or two. Long-term diabetic complications, because now we have induced diabetes, whether they would develop it or not. Almost 40% do develop some sense of neuropathy. And 4 total patients had non-islet function and were referred for whole organ transplant. And here's the kicker, really. Quality of life is improved and the improvement is durable. These patients are able to get back to their life and live the life they would like to. There might be some pain, but it's manageable and they can get back and live the life. They can resume jobs, complete school, do things that they wanted to do and never thought possible. When we did this, we looked at overall survival. And anytime you look at a survival curve over a long enough timeline, survival is going to go to 0 for everyone, right? And it does continue to climb, but we were a little surprised by this 62% at 10 years. We thought that was a little lower than what we would have expected. When we looked at it initially, there were very few diabetic related complications leading to mortality, but a lot of unknown. These long-term outcomes have been demonstrated by other groups. This is just a screenshot of the paper out of University of Minnesota. They've extensively published on this. I'm not going to go through all of it today because I think it echoes a very similar sentiment that this operation is durable, and in the right patients, it is effective. This is the group at Leicester as well, demonstrating their long-term outcomes, showing similar results. And as Dr. Nealon alluded to, that long-term survival, we really want to explore that a little bit more, not just in total pancreatectomy patients, but in all patients that are undergoing surgery for chronic pancreatitis. That survival seemed a little off for us. This was just under 500 patients. I'm not going to go through all this because some was already covered. Persistent narcotic use. Almost a third of patients continue to use narcotics long-term after this operation. Insulin-dependent diabetes, 60% of patients, all comers. Now, half of this cohort was total pancreatectomy outside of transplantation, so it's not all just TPIT. Also of note, almost 40% continue to smoke, and almost 20% continued to use alcohol after this operation. Oops. I put this slide up here because I think this is important. Hammer home this point that really patient selection is key. Selecting the right operation for the right patient in the right setting is optimal. And no difference in outcomes based on a type of operation performed, which I think really highlights the importance of selecting these patients appropriately. And as Dr. Nealon alluded to, the only factor that was associated with worse long-term survival on multivariate analysis was persistent narcotic use. But look at the right-hand side of the screen there. Median age at death was 50 years. Narcotic dependence at 10-year, those patients that had narcotic dependence, 10-year overall survival was 50%. Half of them died within 10 years. We also have a real problem, as Dr. Singh alluded to. Substance abuse was a cause of death in 10% of these patients. Suicide, 4%, and end-stage liver disease, 7%. So we have some psychosocial factors that are really important in the long-term management of these patients and really highlights the need for long-term care. Where do we go from here? I said to you earlier on, the goals of the operation were really to achieve this stable glycemic control. Why not say that's insulin independence?
You have 2 minutes to wrap.
So some of the early data really demonstrated that islet mass was critical in long-term endocrine function. I've personally looked at this every which way I possibly can. In our data, we don't see the same correlation. Even when as far as creating a model with texture analysis, looking at the quality of the pancreas preoperatively to see if we could come up with a model, we came up with a model on how useful it is. I think really the next step in this is we need to understand the islet engraftment process. We see patients with low yields have excellent endocrine outcomes. And so we really need to nail this down. This is where we need to figure out where to go next with this operation. The conclusions are pretty self-explanatory, so I'll go ahead and stop there and be happy to take any questions.
Thank you for wonderful talks. We certainly need more time for surgical talks. Plug. We're going to open the floor for questions, and while we grab anybody, I want to ask Dr. Nealon here. We certainly take care of a different population in children, where we see dramatic risk factors and genetic causes of CP. We still see the referrals and second opinions or post-procedural patients that had undergone a PUSTA, for example, for a dilated dog disease, where they have PRSS1, for example, and, wrapping up from all three talks that a lot of patients need second operations. What are your thoughts on these patients that, in my opinion, will be better served with a TPIT?
Yeah, I mean, I do think that the genetic predisposition for, having mutations that are precancerous is an indication for TPIT. So I think that subset, it's just as Greg just said, I kind of agree with all those. There is a much smaller subset of classic calcific disease in juvenile patients, and those can be given the same opportunities to have the procedures that I've described. But I think if they have RAP and if they have these pre-malignant things, that they are better candidates for a TPIT.
Before our next question from the audience, just a quick note, we will extend the Q&A for another 8 minutes or so. There'll be a break, and then the next session will start at 11 o'clock. So we're going to push the next session back by 10 minutes. So for those of you who are afraid that you may be able to miss a chance to get some coffee or a bathroom break, be still. Yeah.
Okay, so TPIT is great for children with mechanistic causes of pancreatitis, IPRSS1, and CFTR. There's no doubt about that. But for other patients, a 38% mortality rate at 10 years, 95% graft failure, you really ought to stop doing this operation. And the other thing is you need to explain why 2/3 of your patients are women, when loss of the Y chromosome has nothing to do with chronic pancreatitis. And don't blame it on the patients, which you're trying to do there by saying, oh, well, they're narcotics. Why did you operate on them in the first place?
Yeah, no.
Is this working?
Go for it.
Yeah. No, I think those are, it's an important point. I think it's important to also note that patients who are undergoing TPIT for chronic pancreatitis are going to have the same problems as the general population in whom we're trying to diagnose chronic pancreatitis. We have not optimized our criteria. I think as time has gone on and newer series of TPIT are coming out, including that of the post study, you're going to see that patient selection has, I think, become much more refined. We're really trying to avoid doing this operation in minimal change disease and women who might, in fact, have irritable bowel syndrome or functional dyspepsia. And we all know that patients in those categories have undergone TPIT in the past, but it is our strong hope and desire, and based on the data that's coming out of established prospective consortia, that we will not be doing that as we move forward. So I think you're going to see very, very different outcomes of this procedure in newer data sets.
Yeah, no, I mean, I echo some of that same sentiment. I hear your points. I can't explain why there's a high preponderance of women. I can also tell you there's a number of women who come back and see me routinely and are so happy that they underwent it. The proof is in the clinical outcomes. Otherwise, I wouldn't be doing it. The data we try to put on numbers just to demonstrate what we see clinically. Can't always have that. And I think some of these prospective databases are really going to give us some of those answers. Patient selection is critical, though. You're absolutely right. I mean, and that's why I really wanted to echo that. You have to take these on a case-by-case basis. You have to really establish the diagnosis. In some of these patients who don't have the classic morphology, it's really difficult. We have a multidisciplinary fashion. You have, an endoscopist you really trust with what their endoscopic ultrasound findings are. And you have to go on the best available data you have and hope that you're doing the right thing for the patient.
Great. Well, I have many questions for both the endoscopists and the surgeons, but we don't have time for that. But I guess one comment I have is just as a reminder to everyone that the plural of anecdote does not equal data. In other words, in addition, a corollary is that not all data are created equal. Observational data, as Dr. Singh pointed out, with concern related to regression to the mean, be it pain, quality of life, is a really big issue that we need to think about tackling as a field. And so a question for surgeons relates to some comments that were made today as well as yesterday too, relates to the training of future surgeons with an interest in not only managing, but also studying benign diseases of the pancreas to generate these types of rigorous, controlled clinical data to really help us try to, stop needing to use case series or observational data to guide these conversations. So I guess, could you comment on what do you see as the future for training surgeons with a clinical and research focus in benign diseases of the pancreas? What's the path forward?
Yeah, so I'm definitely becoming a dinosaur, but what I will say is that there are finally now some HPB training programs. The problem is I've met some people who went through some of those who still have no idea how to do a Fry procedure. So, enriching the gene pool is a good question. I can do my best of taking some young colleagues and say, oh, come on and let me show you how to do this. I actually borrowed this. I was invited to be with Hans Bager in the 1990s. He had a course every summer and he invited every other pancreatic surgeon in Europe to come to Ulm, and he showed them all, half of the day was in the OR, and he showed them all how to do these things. And that's where I honestly learned how to do it, was by going and visiting Hans Bager 100 years ago. But yeah, I don't know. There's a gap in knowledge that is very, very broad. If anything, I just think that maybe there's a place for writing an editorial. Maybe there's a place for someone to be able to know that you can refer these patients to someone who knows what they're doing. I tell every patient there doesn't need to be one of me in every hospital, but there's patients can go to any hospital they want to, where they'll probably be told there's nothing you can do. And, what do we do with any of this stuff? The internet is helping a little. The National Pancreas Foundation, which we've heard about here already at this meeting several times, is one of those conduits. But that's the problem. There needs to be a conduit for where do people have the skill?
Well, and I think also adding to that, is as medical management, endoscopic therapies continue to improve. You're right. There's a much greater percentage of patients not making it to surgical intervention, which is a good thing, right? But it also decreases the number of opportunities for surgeons to develop that skill set, and becomes harder and harder to achieve, appropriate proficiency in doing those operations.
Last question from Melina.
Yes, thank you. This is actually directed toward Dr. Wilson. Thank you for that beautiful presentation. And one of the studies that is early at our institution now is actually on long-term islet function and outcomes. We call it the LIFT study. So where we're bringing people back for very detailed mixed meal testings and diabetes complications. One of the caveats on the older data is a lot of those patients were tested for C-peptide. So in the patients we're getting back now, actually about 90% seem to have graft function 5 to 20 years out from TPIT if you actually measure C-peptide. But one of the other interesting findings, and I was curious your thoughts on this, is that we also see neuropathy as the most frequent patient-reported complication of diabetes. In fact, if you do nerve conduction velocity testing, we haven't seen a single abnormal study in 70 patients, even those who say they're diagnosed with neuropathy, at least what you would think of as diabetic neuropathy. And my what I've been curious about is, could this be nutritional? Could this be vitamin E deficiency? Could this be a fatty acid deficiency? Could this be their chronic pain syndrome? Is this something else that we're seeing as neuropathy symptoms?
Yeah, no, thank you for that question. I think it's a great point, because, you see these patients and as Dr. Singh, kind of this hyperalgesia and chronic pain, and you wonder if there's something related to that. And is it related to the timeline, how long they've been dealing with the, recurring pancreatitis that leads to that? Certainly. And I think, as you highlight, it's heterogeneous, and some things probably get clumped together, much like, just using a C-peptide level, because that's the data we have, and it's not great. We know that, but we don't have any other data to go off of.
Great. All right. We'd like to thank all of our speakers and the audience. Again, as a reminder, we're at a break. Please enjoy refreshments and the exhibit hall, and then we'll be back at 11 for the next session. Thanks.